Hi, I'm Annemarie Thompson, and I'm a professor of anesthesiology, medicine, and population health sciences at Duke University, where I practice cardiothoracic anesthesiology and critical care medicine. I directed a preoperative clinic for more than 10 years and have been involved in perioperative medicine for more than 20 years through institutional perioperative system strategic planning, clinical practice, research, and guideline development. I would like to thank the American Heart Association for their sponsorship and ongoing support of this perioperative guideline, one of the most and likely the most heavily utilized and cited guideline in perioperative medicine. So let's get to the guideline. The 2024 AHA, ACC, ASNC, HRS, SCA, SCCT, SCMR, SVM guideline for the perioperative cardiovascular management for non-cardiac surgery, which will be referred to as the perioperative guideline, is an update of the 2014 perioperative guideline, which as of this morning has been cited nearly 3,200 times in the literature. The first perioperative cardiovascular management guideline was developed in 1996 and has undergone 3 subsequent rewrites or revisions. This guideline was developed by a writing committee that represents the breadth of specialties that inform the care of patients undergoing surgery. Many members of this writing committee are not just experts in perioperative medicine, but also dedicated clinicians who actively practice medicine. Thousands of hours have been poured into developing this guideline to assist clinicians in applying the latest evidence-based, expert-informed approach to the perioperative management of patients being considered for non-cardiac surgery. I'll hand the mic over to Dr. Kirsten Fleischman to talk a little bit about the rationale for an updated perioperative guideline.
My name is Kirsten Fleischman, and I'm a non-invasive cardiologist and an outcomes researcher. I'm also a professor at the University of California, San Francisco, where I serve as an assistant chair in medicine and associate chief in cardiology, and as a medical director, specifically of our adult cardiac stress and ECG laboratories at UCSF Health. As I recall, this is actually my 4th full perioperative guideline with which I've been involved. And I'd also like to echo Annemarie's thanks to our sponsors, including the American Heart Association, but also to my colleagues on the committee for giving so generously of their time and expertise to this current guideline. And we hope you find it useful. Dr. Thompson asked, why revise this guideline now? Well, as she mentioned, the last guideline for perioperative cardiovascular management around non-cardiac surgery was published in 2014. And the ensuing decade has seen a wealth of important new data regarding perioperative care. So this new guideline is meant to summarize those data and, perhaps more importantly, incorporate them into our thinking and into our management. In addition, this guideline uses the new modular format, which will make it easier to update and keep current in future. And with that, I'll turn it over to my colleague and fellow vice chair, Nat Smilowitz.
Hi, my name is Nathaniel Smilowitz. I'm an interventional cardiologist and clinical investigator at an assistant professor at the NYU School of Medicine in New York, as well as the VA New York Harbor Healthcare System Manhattan campus. I have a long-standing interest in perioperative management and the impact of ischemic heart disease on surgical risks, and I've previously been involved in AHA scientific statements related to perioperative care, but this is actually my first involvement with the perioperative guideline. It's been an honor and a pleasure to work with the AHA-ACC staff and the entire writing committee to prepare this tremendous clinical practice guideline document.
Now that you've met the members of our leadership team, let's go into the details of the new 2024 guideline. I'd like to take a minute to discuss the details of Figure 1, or our perioperative algorithm as it's commonly known. This is the document that is often displayed on the walls of perioperative clinics around the country, and it has some significant changes from the algorithm from 2014. If patients are having emergency surgery or have acute decompensated cardiac conditions, the recommendation is to take a pause at that point. And if it's emergency surgery, don't do further workup. Go ahead and proceed to surgery. But if they do have decompensated cardiac conditions, that should be a signal to pause and not do surgery and treat those conditions before proceeding. The next stage for people that aren't having emergency surgery and don't have acute decompensated cardiac conditions is to really take a look at what is the patient's baseline perioperative risk. For that, we advised, as in the prior algorithm, to use a risk calculator. Common risk calculators abound. The RCRI is one, and probably the most commonly used, to determine the risk the patient has for adverse cardiovascular events. However, our writing committee felt, in addition to that there were certain medical conditions or states that are not adequately accounted for in any of our current risk calculators. So we thought the better part was to take a risk calculation of the patient, but also look at these associated cardiac conditions, which we called cardiac risk modifiers, like severe valvular heart disease, pulmonary hypertension, frailty, the presence of a pacemaker or ICD, prior coronary stents, or having a prior bypass, for instance. From that dual assessment at that stage, it really subdivides into three arms beyond that. One is for people who have low calculated risk by risk calculators and don't have any of the following risk modifiers, such as frailty, prior stroke, or cardiac devices. If they have none of those risk modifiers and again are at low calculated risk, the recommendation is to go ahead and proceed to surgery. However, if patients do have an elevated calculated risk from the risk calculator, but no risk modifiers, again, such as pulmonary hypertension, valvular disease, it is in the algorithm for you to refer to, you can consider a 12-lead ECG and guideline-directed medical therapy prior to the next step. In the third arm, if the patient has any risk modifiers, regardless of what the risk calculation score is from the risk calculator, there is some additional workup that could be considered. At that point, we'd like to know what the patient can do. And assessing the functional capacity of patients is still very important in this guideline. Using the DACY method or METS, referred to in the algorithm, you can determine if the patient has any impairment of functional capacity. If they have significant impairment of functional capacity, then the question becomes, would further testing impact patient care? And if the answer is yes, that the belief that further testing would change the course of treatment, then this is a third stage of the algorithm, which is new from the 2014 algorithm. In this part, we're actually incorporating biomarker assessments as a way to further risk stratify patients. In the next step, biomarkers can be obtained. If they're normal, the recommendation is to proceed to surgery. But if they're abnormal, that's a time for multidisciplinary team discussion regarding risks and benefits of additional cardiac evaluation. And for patients with abnormal biomarkers, if decision is made to pursue cardiac evaluation, there are some non-invasive steps still suggested, such as echocardiography or non-invasive stress testing or CCTA. If those are determined to be negative or show low-risk findings, then it's recommended that the patient proceed to surgery. However, if any of those show elevated risk findings, at that point, the team can consider alternative strategies, deferral of surgery, non-invasive or invasive treatment, or palliation. They can also consider proceeding to surgery at that point, with the recommendation that postoperative troponin surveillance can be done. So now that we've presented the algorithm, I'd like to ask Kirsten and Nathaniel to comment a little bit on the algorithm and what they find new or interesting, or what clinicians who are taking this in for the first time, it is comprehensive, what they would suggest that they focus on.
One of the things that I think is new to our algorithm is the preoperative biomarker risk assessment. We've learned over the past decade that relatively simply obtained biomarkers can help us to risk stratify our patients further. And so you'll see that traditional testing, for example, stress testing, or now CCTA, comes a little bit further down the algorithm. So I really think that that is a an area for people to focus on. And if they're not particularly familiar with these biomarkers, I encourage you to read the guideline because it goes through in detail the data that we have on these points.
I think that's a great point, and I completely agree. I think that's a major change in the guideline. It really does de-emphasize the dedicated cardiac testing, which is expensive and can lead to downstream implications that are not necessarily advantageous to patients. So that the biomarkers really do add quite a bit. I think Annemarie mentioned this earlier, but the risk modifiers in the box really is a major change in how we think about risk assessment for these patients. Many of the risk calculators don't include things such as recent stroke or the presence of a pacemaker or a defibrillator. And those considerations really do impact perioperative care and may require additional team discussion before you send somebody to the operating room.
Yeah, I think one of the major changes in this whole algorithm is the algorithm from 2014 really looked to identify patients that were at increased risk of coronary ischemia or myocardial ischemia, whereas I think this takes a more holistic or comprehensive look at cardiovascular disease. And obviously no algorithm can incorporate every cardiovascular risk in it, but I think this algorithm really tries to put some of this together.
I also wanted to call out the myocardial injury after non-cardiac surgery and the troponin surveillance at the end of this diagram. This is something that was added to the flowchart from the 2014 perioperative guidelines. And I think this is an important consideration because an elevated troponin in the postoperative setting can really identify patients who may have subclinical cardiovascular disease and are at increased risk of long-term, short and long-term adverse outcomes. Myocardial injury occurs in about 20% of patients, and it may change the care of somebody who doesn't have known cardiovascular disease at the time of surgery.
So Nat, you've also mentioned with myocardial injury after non-cardiac surgery that it's important to identify these patients, and you've touched a little bit on management. Can you talk about what is still left to be learned with the management of patients with myocardial injury after non-cardiac surgery? Like, what should the clinician do once that's identified?
Yeah, this is a really challenging area, and it continues to be an area in need of investigation. We have observational data to suggest that statins, aspirin, and antithrombotic therapy are probably beneficial for these patients. We have a randomized trial of anticoagulation, which reduced a composite of cardiovascular events in the year or two after non-cardiac surgery in patients who develop myocardial injury. But we still don't have a complete consensus or a clear framework for the optimal care of these patients.
Kirsten, you're a cardiologist also. What do you do when you get a patient who is identified as having MINS?
Well, as Nat mentioned, we have somewhat limited data on actually how to treat MINS, but we know that it portends increased risk down the line. So I'm going to do a very careful evaluation of that patient. I'm going to treat every risk factor that I can manage effectively, and certainly I'm going to surveil that patient as far as future ischemic risk is concerned. Nat, do you do any additional testing in those situations or more risk factor management?
Yeah, I think it's really about risk factor management in these patients. Certainly it might make one give pause to what might otherwise be symptoms that are ignored in the course of clinical care subsequently. But my goal is really to make sure that they have optimal lipid control, optimal risk factor management, and I do weigh heavily the consideration for at least an antithrombotic agent long term, whether that be aspirin or a different agent.
I'm just interested in hearing what do you think are the most important or maybe surprising take-home messages that clinicians should know?
Certainly one of the takeaways from this guideline is that cardiovascular screening and treatment around non-cardiac surgery should generally adhere to the same indications as non-surgical patients. Obviously, it has to be timed to avoid delaying the surgery, and really with an emphasis on trying to avoid over-screening and over-treatment. For example, the guideline advocates for using stress testing judiciously in those undergoing non-cardiac surgery, especially those at lower risk, and generally only in those in whom testing would be appropriate anyway, independent of the planned surgery.
Yeah, I agree that that's a really important change in the guideline. I think there's been a lot of stress testing that may not have improved care over the past years, and hopefully this new set of guideline recommendations and the algorithm for perioperative care will decrease the emphasis on ischemic testing for ischemic heart disease in the preoperative setting and restrict that really to the highest risk individuals. I think the medical management also warrants sort of a new consideration. So this guideline highlights the new therapies for the management of diabetes and heart failure, the sodium glucose cotransporter 2 inhibitors, which can cause ketoacidosis in the perioperative setting. And so while many of our patients are taking these drugs, empagliflozin or dapagliflozin or other agents in the class, it can have adverse effects in the surgical setting. And so the new recommendation is to withhold these drugs 3 to 4 days prior to non-cardiac surgery to avoid the risk of perioperative ketoacidosis.
Yes, I think that's a really important point, that a lot of practicing anesthesiologists, cardiologists, surgeons, internists even simply don't realize the risk of ketoacidosis in that patient population. So I do think that's an important consideration. So many patients are taking these medications, and as you said, not just for diabetes, but for cardiovascular, cardiorenal protection, that they are very commonly prescribed medications, and clinicians really should be aware of the risks. I think one of the take-home messages that really stuck out to me was the need to pay attention to atrial fibrillation and stroke. And in particular with stroke, I think people have always struggled with, well, what is the timing of non-cardiac surgery after stroke? And it turns out you really need to think about that. There is a U.S. study as well as an international study that looked at the timing of surgery after stroke, and it's one of those cases where the sooner is definitely not the better, and giving a little bit of time for recovery or management can prevent stroke with non-cardiac surgery. And perhaps pushing that out at least 90 days could prevent further morbidity from stroke.
Yeah, transient perioperative atrial fibrillation, as you mentioned, is also something that really can't be ignored. Even when it's just a few hours of postoperative atrial fibrillation with a return to sinus rhythm, that patient is at increased risk for stroke over the long term. We now know that those patients need to be monitored carefully in the outpatient setting and considered for antithrombotic therapy long term. Their risk profile is different than the patient who sails through surgery without perioperative atrial fibrillation.
Right, and I think that's such an important point. I mean, most clinicians would just breathe a sigh of relief that it was self-limited, discharge them from the hospital with no follow-up, and as you had stated, this can lead to further stroke, maybe not in the immediate perioperative period, but later on.
So I'd just like to end by encouraging folks to take a look at the actual document. I think it's a great compilation of the new data that we've acquired over the last decade or so, and hopefully a useful framework for helping you think through your decisions about your patients, certainly meant as an adjunct to your good clinical judgment.
Yeah, and on behalf of the writing committee and the writing committee leadership, I would like to thank the American Heart Association for really the support to revising these guidelines, rewriting them. This has been literally a decades-long process from the time that perioperative guidelines were first written, and we all appreciate that the American Heart Association understands and supports the work that is done in this area and the work that will continue to be done in this area. Thank you very much.